At OnlineMedEd, we walk you through every topic in detail, so you're ready for the boards and the wards. Addiction 1, in all honesty, is going to be low yield for any test, but it is going to be high yield for actually dealing with people who might have substance abuse. What we're going to do is engage the DSM-5 changes to substance abuse disorder and talk about some of the mnemonics you can use to help screen and treat people. At the very end, we'll discuss addiction and how it's not just substance abuse. So the big change from 4 to 5 was that we now have a spectrum of disorders all called substance abuse disorder. Use, abuse, and dependence are no longer words that we use. Instead, it's all one disorder with variable severity. And the severity is based on how many of the checklist items the person has. And there are 11. So remembering them all is hard. And this is something that's going to be true of substance abuse disorder. On the test, it must be overt and obvious. In real life, it'll be much more subtle. The difference between use and abuse is going to be primarily related to impairment. On the test, it'll be florid. In life, it may be gray. So what I've done is I've taken those 11 things and I've broken them down into 4 major categories to make them easier to remember. Let's go over each. The first is control. That is self-control with the substance. If you use too much, that is more than intended, that is a sign of a loss of self-control. This doesn't mean you had 1 extra shot because your buddies egged you on after your shelf exam. It's you only intended to have 1 drink and you had 1 bottle. It may also be the inability to cut down or stop when you want to. Similar concepts. Other issues with self-control are going to be things like spending too much time trying to get the substance, either the things you do or in order to get it, or you literally spend a lot of time getting it. And the big thing, we'll come back to this as we finish the lesson, is cravings. That is the feeling like you must do the substance. Social impairment is the next category, and this is really required for there to be a disorder. Now, I'm saying that because that is the DSM-5 clinical definition. Someone might still have a disorder even if they're high functioning and don't appear impaired. Social impairment can be in any of 3 categories. That is the inability to fulfill obligations at work or school, and that's not showing up late once or forgetting to turn in a homework assignment. That's partying until 7 a.m. the day before a shelf exam, or not turning in your quarterly report as is your job title. The other thing is social impairment in regards to relationships. Friends, lovers, family. If you have a glass of wine and don't talk to your sister because you've hated her since she was 3, that doesn't count. But if you've had a relationship that you've wanted to maintain, but the substance comes first, or they have separated that relationship over the substance, that counts. The last is activities. That is, you used to do things that you like to do, but now you do the substance instead. I'm going to pause here and illustrate how difficult this can be. If someone has all of these, they're going to actually meet the criteria for severe substance disorder. Watch what I mean. Someone who works too much, and every time they try to take a vacation, they can't. So instead of going on vacation during residencies, they work 80 hours a week, putting all of their free time into doing what they're doing, despite having some sort of obligation impairment and getting spoken to by the director of his medicine group once or twice, impairing relationships, losing friends, and stopping doing all the things I used to like to do. Instead, what I do is teach you via videos. Do I have teaching abuse disorder? The point I'm trying to make is that this checklist is good, but hopefully you don't think I have a disorder because I love doing OnlineMedEd. The problem is going to be in real life. It is challenging to identify the people who truly have a disorder, and the checklist is not going to be enough, especially if the person is high functioning. They may remain in denial. The test is not going to make it that subtle. They're going to be at hit rock bottom. They're going to be people who have lost everything, the people who are coming to you in the time of a crisis. That's easy. But in life, it's going to be way harder to decide, does this person have a disorder or are they just functioning with normal behavior? I like to use the risk-taking behaviors as a marker of someone who's having a problem. That is either putting themselves in hazardous conditions, using the substance during sex or driving, and that's not with partying with their wife. It's putting themselves or others in danger despite using the substance. And that includes having sex in order to obtain the substance. The other thing is complications. Right? Either you've suffered a health complication or have legal trouble and continue to use. This is also really troublesome in real life. Right? You had a great date, you had one more glass of wine than you intended to, you drove home, you're a little tipsy, but were you 0.06 or 0.1? I don't really remember. But I had sex with a girl that I was having a date with. Is that substance abuse? What happens after that date? You didn't go home with her, but instead on your way home you got pulled over by the cops. The next week you go back out and have another glass of wine. That area of gray makes this really hard to spot it. Even with the risk-taking behaviors included, there may be a substantial amount of denial, but also a substantial portion of normal behavior, which makes this really hard to spot and really hard to convince somebody who isn't at rock bottom they have a problem. The last is going to be the physical or the pharmacological changes. That comes in the way of tolerance. You need more to feel the same thing, and withdrawal. Now, withdrawal is an obvious one. If you are withdrawing from a substance, you are using way too much, right? And that's a done deal. Not according to DSM-5, that's only one of the 11, but if someone withdraws from a substance, that means they're a chronic habitual user and they're using too much. That's it. They're done. The diagnosis is going to be made clinically. But it'd be nice if you could screen somebody and catch them before it becomes a real problem. The test, again, will hit you someone at rock bottom who's positive floridly. With screening, there are two organizers I want you to know about. The first is CAGE. This is the one you probably learned about in the preclinical years. C stands for cut down. Have you ever tried to cut down? Do you get angry when someone talks to you about the substance? Are you guilty of the things you've done while using, or do you feel guilty about using? And E is for eye opener. Do you need to use to start the day? This, like withdrawal, is a huge red flag. The American Academy of Pediatrics has introduced a modified version of this called CRAFT with 2 Fs, which makes it more specific for adolescents. And this is also important. It is normal behavior for an adolescent to engage in alcohol, marijuana, to break the rules a little bit and to experiment as long as they're doing it with friends and as part of experimentation. CRAFT is an opportunity to catch somebody who might be developing a substance abuse disorder. Most kids who use drugs and alcohol don't develop substance abuse. But the earlier an adolescent is exposed to substances, the more likely they are to develop substance abuse disorder. Most don't develop it, but some do. And the concept of a gateway drug, especially in adolescents, those that are easily obtained, that then progress on to something harder, alcohol, marijuana, leading to cocaine or heroin, does exist. But most kids are just experimenting. So while this will not be on the test, if you're in a pediatric clinic, this is something you ought to know. C stands for the car. Have you ever used the substance while driving? And since it is a normal thing for kids to experiment, then they usually do it in peer groups. If they're using R, the substance, to relax, or they're using the substance alone, that is also a red flag. The 2 Fs stand for trouble with friendships. That is, they're losing friends over the substance, or an obvious sign they're using too much, that is, they forget stuff they've done while using. And T, very similar to substance abuse disorder, is going to be trouble, either with the law, parents, or teachers. Do know CAGE. You don't necessarily need to memorize CRAFT. But after you've made the diagnosis, you want to be able to determine the severity. And the severity is determined by the number of points on the checklist. 2 to 3 is mild, 4 to 5 is moderate, 6 or more is severe. What used to be called substance dependence is now severe. What used to be called substance abuse is now moderate. But as I described, just this job that I do teaching here at OnlineMedEd gets me to severe substance abuse disorder if the substance is teaching. And that's also important. We call it substance abuse disorder, but it is true of activities like gambling or sex, just as it is substances like alcohol, cocaine, or cigarettes. And as you treat this, it becomes even more complicated. Most substances do not have a pharmacologic component. The common ones, like opiates, alcohol, and tobacco, do have some pharmacologic component. What works best, most often, is group therapy. Joining a program like AA, where you meet with other people who have substance abuse disorder, you relate, you talk about it, and you keep each other clean. All along the way, you can help the patient with psychotherapy. And psychotherapy is a general, vague term that means any sort of therapy that you do to help the person stay clean. But it's also important to realize that 50 to 90% of people with substance abuse disorder who get clean are going to relapse. And it's important that you educate your patients that relapse is okay. They can fall off the wagon. They just need to get back up again and get clean. It's not an excuse to give up. In psychotherapy, there's another advanced organizer called frames. Not because it's in this order, but because it helps you frame how you're going to interact with the people who have substance abuse. Most people with substance abuse will deny it, won't even admit that they have a problem. And those that do are generally going to be judged by other people. So you need to frame it right so that you can actually help somebody. The F stands for feedback. You should give feedback, both positive and negative, on the decisions they've made or the actions they've done. R stands for responsibility, ensuring that the patient accepts responsibility for their actions, for staying clean or for relapsing. It's not anyone else's fault. It's okay to relapse, but it's their responsibility. You can offer advice. And because no one therapy works better than another, as you give that advice, you have to offer M, a menu of options. And you work with the patient to figure out which one works best for them. S stands for self-efficacy. That is, showing the person that by being clean, they're doing better. And E is probably the most important. That is empathy. People who have substance abuse disorder, especially those who have the disease of addiction, will be judged by everyone else. They're scum. They're doing it to themselves. Most of their family has already let go of them after helping them repeated times, and they're fed up with it. What they are met with is constant contempt. You may get burned by someone who is an addict or has substance abuse. You might get tricked. You might get lied to, cheated, or actually substances taken from you. You might even know someone who's done this to your family. It's very difficult as a human to tolerate that sort of behavior. But if you as a physician demonstrate that you know what they're going through, you demonstrate empathy. Yes, you might be tricked, but you also might get someone clean. Empathy comes in two ways. There's two things I want to teach you. The first is the stages, and this stages might actually be tested. There are 5. Pre-contemplative, contemplative, preparation, action, and maintenance. It's very easy to give you an example of someone's behaviors or activities or mental state and ask you what stage they're in. Pre-contemplative essentially means denial. Even though they have a positive checklist that's floridly positive, they've hit rock bottom, they don't admit it. Contemplative means they've accepted that they have a problem. And you've probably heard the phrase, the first step is admitting you have a problem. You can't get clean if you don't recognize at least that you have the problem. Preparation is the first steps. They're ready, they're thinking about the things they want to do. Action is the actual behavior change, whether it's smoking less cigarettes, using a medication, or alcohol cessation. The behavior change is the thing that gets them clean. And once they've done that, maintenance is where they sustain those behavior changes and don't relapse. Because most people will relapse, it's important to go back and forth between action and maintenance. If they relapse, re-engage the same behaviors that got them clean and get them clean again, recognizing that most people will relapse. The other thing in the way of empathy is understanding the disease of addiction. Substance use and abuse is separated by the fact that using the substance causes some sort of impairment. Addiction is a disease. The pathology behind it is a neurobiological predilection to require a substance to feel normal. I'll show you what I mean. This is the quality of someone's life on the chart. This dashed line represents someone who goes through life completely sober. People who are not addicts will go through life right around that dashed line. Then they go out on a Friday night and have a glass of wine, and they get a little giddy. They feel good. And then you pass step 1. Fuck it. Get hammered. Right? You party really hard, you have a great time, you black out, the next day you're hungover, and that's awful. And after a bowl of soup and a weekend to recover, you go back to normal. Step 1's over, anxiety relieved. What happens to an addict? An addict is generally going to float by in life just under the line. And the first time they use, they feel really good. Better than you ever will, ever. But afterwards, they feel less. And the return to baseline is not baseline. They reset their quality of life so that it is worse than they were prior to using. So that the next time they use, even though they have a higher high, they never achieve the same level as they did. And the come down the rest of their life is even worse until they get to the point where they use only to feel normal. That is, when they're sober, they're miserable. But when they're using, they feel the same way everyone else does, sober. That need, that craving, the need to use a substance to feel normal is the disease of addiction, which is why people do the things they do in order to achieve that substance. There is a spectrum. Substance use, no problems. Substance abuse, use of a substance with problems. Addiction needs to use the substance to feel normal. So in this lesson, you're not going to learn a lot of things you're going to see on the test. Sure, the checklist for substance abuse disorder, recognize the CAGE questionnaire and the stages of substance abuse. But a lot of this is more about educating you on the disorder and the disease of addiction and how you can interact with people, learning that it's really going to be way more gray than most people present with. On the test, it's going to be obvious. It's overt, it's frank, hit rock bottom. But you can help people by identifying disorder early, by screening your patients, and then engaging them in a way that helps them rather than judges them. That is Addiction 1, substance abuse disorder.